Janet, think you're muted?
I'm muted, okay.
Okay.
My name is Janet Burkhead. I am the Adult Services Librarian at the Long Branch Free Public Library, and I will be the moderator for this program. Welcome to Breaking the Stigma, Suicide Prevention in the Black Community. I need to ask a favor. Since we publicize this program through many different types of organizations, it would be helpful to know which of these were the most useful in getting the word out. Please use the chat to tell us the name of the organization or business from which you heard of this program. If you do not remember the name, the type of organization will be sufficient. Please be advised that this program is being recorded and will be available on the library's YouTube channel after it airs. Hold on, I think somebody else needs to know how to get in. Adult Services. Type in the bit.ly that's on the screen. That's on the flyer that I sent you. Type that into your browser and it'll take you to the meeting. Yep. This is going to be a little crazy. People are having a little trouble with the method of getting on. I also want to address the elephant in the room. Why did this white lady organize a program on suicide prevention for the Black community? The answer is in two parts. The first is my own experience of therapy. I had seizures when I was a child. Although they eventually went away, I was bullied in school for many years. Because of this, my mother had me in play therapy, starting when I was 8 or 9. It helped. I saw other therapists at other difficult times in my life. Again, it helped. The second part of the answer has to do with the way I learned about the stigma in the Black community against seeking mental health care. For several years, I volunteered at a youth group in Asbury Park that served minority youth ages 6 to 18. Later, I became a mentor to special needs twins who attended that youth group, one of whom became my goddaughter. Through my volunteer work and mentoring the twins, I got to know other members of the community. The lifestyle of one young woman I got to know seemed to indicate a lack of self-esteem. So I suggested that she see a therapist. Her response was such an adamant rejection of the idea that I never suggested it again, but that conversation planted the seed for this program. I'm hopeful that the questions I have prepared for the panel will answer most of the questions you have. However, if we don't cover something you wanted to ask, put your question in the chat. We will try to leave time for a question and answer period. Our panelists are Nakia Blair, Tina Onikoyi, and Amber Raley. Nakia has a Master of Science degree in social work. She has been employed as a certified social worker in the Long Branch schools since 2002, where she has worked with children, adolescents, and families. She is currently the supervisor for school counseling services for the district and the program supervisor of the school-based youth services program located in the high school. Tina has a Master of Science degree in mental health counseling and another in clinical psychology. She is a licensed professional counselor and a doctoral candidate in clinical psychology with a specialization in health psychology. She is the clinical director of Wellness Meets World in North Brunswick. Amber has a Master of Arts degree in counseling. She has worked in the New Jersey Children's System of Care, where she has held several positions for 20 years. She is currently a licensed professional counselor at Empower You, where she provides therapy to youth in their homes and communities. She meets her clients where they're at, literally and figuratively. She never gives up. Amber's approach to therapy is unique, and she's able to help people reach their goals. Hold on, somebody else wants to know how to get in.
Janet, just keep going. I've got the admits.
Lisa, should we wait for a couple more people to join, or should I go ahead with questions?
Janet, go ahead. We're good. I've got it if anyone joins us.
Okay. The first question has three parts. For the first part, I'm going to start with Nikia. How does the way therapy for mental health is viewed in the Black community compared to the way it is viewed among people of other ethnicities, in your opinion?
So in some Black communities, there may be a higher degree of stigma associated with therapy due to many different factors, I feel, such as historical, cultural, societal factors. I believe the stigma can really discourage some individuals from openly discussing or seeking help for mental health concerns. There was an article that I read about a couple of months ago that talked about this topic, and they found, based on some statistics, that 25% of African Americans actually do seek mental health treatment compared to 40% of white Americans. And in their findings and the research, one of the statistics that was highlighted was being healthcare is one of the #1 main concerns. In Long Branch public schools, where I work, in the community that I've been in as part of for 21 years, we have a very diverse community, and breaking the barrier in general for many of our families has been definitely a topic of concern, and being able to provide our families with insight, being able to build trust and community with them to be able to share and elaborate and allow the children and also the families to be able to receive mental health services within the Long Branch community.
Thank you. Tina, same question to you. What is your experience of this?
Thank you so much for asking. I definitely find that context matters. So whenever we're sort of reviewing or exploring the way that a particular group of folks are experiencing something, we want to understand what the context is. How are they seeing it from their perspective? I think the first thing that comes to mind is representation. And I don't necessarily think that that is necessarily the first thing that folks see in the Black community. And then also the theoretical approaches that we are taught in our programs are very much created by white male individuals. And I don't know if they're always, there's definitely an exclusion of the Black community in the research as it pertains to these approaches. And so when perhaps even people do go to therapy, they may not be met with the kind of support that is necessary in order for them to feel comfortable in the therapy.
I'm sure that is part of the problem. Thank you. Amber, same question.
So I work with kids, and a lot of my kids are court involved. So some of the things that I'm seeing is that, parents are frustrated. So it's invasive, it's time consuming, and it's inconvenient because I'm in this situation because of my child. In old school, we don't tell people what goes on in our home. Mm-hmm. And what I hear sometimes is, even if they look like you. So it's not always open arms that we're welcome with. Most of the time I'm fine, but sometimes it's, even if they look like you, we handle our problems inside. It's not your business. So it's just like getting to know people, trying to find out the why. Why, what do you think therapy is? Let's talk about that. And really unpacking why they're afraid and making them feel comfortable and explaining things in a way that they understand and trying to be helpful. That's the
Thank
goal.
you. Thank you. My part two is, what do you think is the cause of the stigma in the Black community regarding seeking therapy for mental health? Several of you have already answered that, but Tina, do you have anything to add to what's already been said?
I would say
On
that,
the why?
sure. I think that there's probably more than one cause. You know, it's a loaded question that you're asking. But I would definitely say, I think the narrative would be around the fact that therapy is sort of like, I'm indicating that I'm weak, right? And
Right.
the intention or most desire for most people in the Black community, at least that's what we've been taught so often, is that I want to be strong, like my mother, like the people that have come before me. And so if the perception is that therapy means that I'm weak, if I have some challenge, if I can't handle this on my own, then there's something wrong. But I don't want people to know, kind of alluding to what Amber said, people need to know what's going on in the family, what's happening. We just gonna figure it out on our own. And so I would definitely say that's sort of part of the stigma challenges in the Black community.
Thank you. Amber, anything else on the cause that you wanted to add?
Absolutely. We suffer in silence, Black men and Black women. Black women are the Black backbone and the glue. Black men provide and protect. So when that's difficult, when you don't want to, when you can't, whatever the reason that you don't fit the stereotype of what you are told you should be, right? Again, I work with kids, the trickle down. We're doing these things that seem like they are effortless, right? We're doing it all. We're working, we're cooking, we're taking care of you. And it sucks sometimes. That's the reality. But we act like it doesn't. We hold it all in and then we explode. And our kids don't understand that. They don't know that you had 1,000 things inside. And when they ran up to you to tell you that one thing, that was 1,001. Guess what?
Yeah.
Kids do the same thing. They got 1,000 things inside of them too that you don't know about, because we have taught them to just, right? Tina just said it. Strong to us. That's what we were taught. Strong meant you keep going. You don't say anything because saying something is deemed a complaint. I did it. Why can't you do it? Right? So the strength is talking about it. It is a strength to be able to say, you know what, it is too much. Or I know I'm going to make it through, but I still need to talk about how it's making me feel right now, today. So I think that's one thing. I think the other thing is, back in the day, people just went to the doctor when they were sick, when something was broken, bleeding. So if that's not happening, I don't need, right? I don't need to go. Can't ask for help, can't accept help when it's offered. So it's a duality there. There are so many reasons, why people don't.
Yeah. Thank you. Nikia, anything more on the cause?
Yes, Amber, absolutely. Amber and Tina, you guys were right. You were both right on suffering in silence and that being strong mentality. Absolutely. The cultural beliefs and the practices, and they definitely have a huge influence on perception of therapy, and I believe that seeking support from religious and spiritual leaders, family, community networks is where, our Black communities end with, and that's where they maybe feel safer with. So that suffering in silence, not asking for help, staying strong and blowing up, absolutely. And then you see those cycles repeating, and then it like repeats and repeats until there's that opportunity for it to be broken. And so I love being able to be a part of this and being part of this conversation, so it does get the word out, and that our families and our communities break that and make that change, so that way it's asking for help is not a sign of weakness. It actually is, on a deeper level, a sign of strength. So being able to express themselves, being able to express ourselves, being able to teach people that we are all able to ask for help and find that strength is something that is huge.
Thank you. Starting with Amber, is the degree of stigma affected by an individual's socioeconomic status?
I work in a system of care, so all of our services are free to everyone in the state. All
No,
the
no, I
No,
meant the reluctance.
I know
Is that
what you
due to?
I know what you mean. I got
Okay,
you.
sorry.
I got you. Okay. So
Okay.
for me, for what I do, that is not an issue ever. I've always worked with only children. Is it an issue? Yes, I can see how it can be. It should not be an issue because mental health crosses all the barriers that we as a society create. If you have to be deemed lower class, right, and all of the things that come with that, I can see why you don't feel comfortable to seek it out. If you can only be matched with the provider that is covered, right? You only have X amount of sessions, certain things that you may need are not covered or not covered whole, right? You can't afford the copay. So yes, those things do matter. They shouldn't though.
Yeah.
That's what I'm saying. So for my purposes, I never have that experience. In the world of adults, that is absolutely an issue, but it shouldn't be because no matter where you are in life, mental health affects us all equally.
Amen to that. Nikia, same question.
Sure. So the access, I think, to mental health is sometimes can be limited. So I definitely agree with Amber. Finding someone, and I've had several families that would reach out to me, particularly to find and connect with a African-American, a Black therapist, a male, a Black male. So having that access, you know, can be even right now within schools, out of schools, you know, we have a small pocket that we definitely refer to. So being able to have the access is something that I try to keep, you know, and I'm thankful to be able to meet Amber and Tina here. So you will be written down and will be definitely a referral partner to be able to share those services with our students that definitely seek those services with someone of color.
Thank you.
Yes.
Um,
So I would also say the same, absolutely, that I think that socioeconomic status plays a part in stigma in the Black community. Again, I like to really take it back and think about context, right? So the larger picture, yes, we have these individual experiences, but like structurally and like if we're thinking even, let's say, access to support, right? But we're thinking about therapy, but also what about other ways that people experience or have access to professionals, teachers? That's a big one, right? And so how are these teachers impacting the stigma too, right? It's all like a system and we're all part of that experience. And so if these communities, let's say, have lesser support financially, you have burnout, right? How are these professionals working with these students, right? That's going to impact their experience of mental health. And absolutely the way that they feel comfortable sharing, right? If right now I don't have time to talk to you because there's no one else to support me in the classroom, just using, teaching as an example, but like, I don't feel if I'm just comfortable enough to talk to you and I've lost the opportunity, like Amber mentioned before. Like it's so critical that we do support communities and create opportunities for resources for folks, because otherwise I think we're continuing to perpetuate this stigma that we're experiencing for the Black community.
Thank you. Question 2, let's start with Nikia. Psychiatrists, psychologists, and licensed clinical social workers are all authorized to provide mental health therapy. Please explain the similarities and differences between them, and also tell us about your educational background as a therapist.
Sure. Okay, starting off with psychiatrists, psychologists, and licensed LCSW, licensed clinical social workers. As you said, they are all of those trained professionals can conduct therapy So I'll start off with a few similarities. I know each person will also be asked the same question, so I'll share some similarities. Mental health care providers, all three professionals are definitely trained to provide the mental health care and support to families, individuals experiencing emotional, psychological, behavioral, and anything, grief, any concerns that may come up. Therapy and counseling, psychiatrists and LCSWs can offer those types of services as well. The assessment and diagnosis, they're trained to provide the diagnosis for mental health disorders and conditions that, anything that may come up that may vary. And also confidentiality, they're bound by ethical and legal standards for patient confidentiality as well. They all definitely play important roles in healthcare training, scope of practice, and, areas in their expertise. I did receive my Bachelor's of Arts in Psychology from the Richard Stockton College and my Master's in Social Work from New York University in 2002. So I just shared some of the similarities and I left some of the differences to give Amber and Tina an opportunity to expand on something else.
That works. You've been doing this work for a while. If you finished in 2002. Thank you.
Yes, you're welcome.
Tina, do you want to tackle either more similarities or some of the differences?
Absolutely. And so thank you so much, Nakia, for sharing some of the similarities in terms of some of the differences. Psychiatrists are typically those who prescribe medication. And so you might have, they may provide therapy, but for the most part, you find that they are most focused on psychopharmacology. Psychologists are typically known, and that's what I'll be soon. We're working on this dissertation, almost done. They're mostly known for doing psychological testing. So those are like your IQ testing, personality assessments, immigration evaluations, those sort of assessments. And then you mentioned licensed clinical social workers. I'm actually a licensed professional counselor. And so different in the way that we're trained, but we are able to do the same practice of counseling and therapy. Depending, for LCSWs, they've decided that that's their specialty that they'd like to focus in on, the clinical work. And LPCs, that's sort of our training from the get-go. And a little bit about my background, like you mentioned, my master's is in mental health counseling. I went to Monmouth University, and I also have another master's in clinical psychology, and just finishing up this PhD in clinical psychology with a health specialization. So each of my experiences has been vastly different, although individuals in each of these can do similar things. The training is different.
Okay, thank you. Anything to add, Amber?
So a psychiatrist is a medical doctor, and as Tina just said, she's going to be a PhD. That's the difference, and we all can do. We can all diagnose. That's the only thing. My background is different. In vocational counseling, we learned about the happenstance approach. So basically, wherever you start off, you're going to end up where you should be in your professional career. I always wanted to be a lawyer, and my undergraduate degree is actually in political science. I started in the field. So I did residential work, I did direct care, and it was like strength-based. So it was a challenge. It was interesting. It was very aggressive. It was a lot of physical aggression, fights every day. I saw a lot of things, and I was a Black lady, young and Black, 21, 22. They yelled, I yelled. They cursed, I cursed. Very challenging. And I was 23, 24 when I was like, why? Because when I was a lawyer, it was always, why do people do the things they do? And it transitioned very well into this. So something always happened to cause a behavior, and a behavior is telling us something, even when it's aggressive, even when we don't like it. Something happened that triggered that behavior, and I want to know what it was. So when I started to think that way, I started to calm down. I started to be less reactive, and I'm here. And I do very well with the same type of kids. So I said, you know what? I'm going to get a master's degree. And I did. And I did. And I worked in the field the whole time. So I did direct care. Then I did case management. And I did that the entire time I was in my master's program. I went to Rider University for both. It took me 4 years. And when I graduated, I did therapy in a group home setting. And that's how I earned my clinical hours. Challenging, but very, very rewarding. I have a passion for working with the more challenging youth. I thought about it today when preparing for this. It's like a puzzle, you know, all the pieces are there. You can't tell what it is yet. And then you put it together and it's like, aha, it's still something beautiful.
Thank you. I'm hearing that all three of you have a passion for this work, which is great to hear.
Absolutely.
Want to make a quick comment about what
Sure.
Amber mentioned about like particular working with different students or children. I've just the question before we were talking about stigma and how it impacts the Black community. I wanted to put into this space sometimes the challenges when there's not like a cultural competency, right? Folks then are either overdiagnosed or underdiagnosed in the Black community, right? So we're not thinking about the picture. Again, that context is so important. We're not thinking about what are these children experiencing in the home. So like, maybe it's okay that like they're a little restless, right? Maybe, but we're like, oh, these people got OCD, they have ADHD, they're bipolar. We're just throwing diagnoses, giving them medication, when really we're not addressing the structural and systemic issues that are at play here. So I want to throw that into this space.
My mother and I referred to my brother as Tigger when he was growing up. So I hear you about that bounciness and energy. And it's not always something that needs to be diagnosed. Question 3, starting with Tina. There are different schools of thought based on a variety of theories and different techniques used in therapy. Which school of thought do you subscribe to, and which techniques do you find effective in your practice? Describing them if you can in layman's terms.
So I use a conglomerate of different approaches. One that's pretty common, most popular, is cognitive behavioral therapy. I also use acceptance and commitment therapy, some reality therapy. So to break that down a little bit, cognitive behavioral therapy is the approach where we're exploring and understanding the way that folks' thoughts impact how they feel, how their feelings impact what they do, and how we continue the cycle over and over again until we make a break in that cycle. Reality therapy is very much about taking account and for our experiences and the choices that we make. Acceptance and commitment therapy is essentially being present to our experience without the resistance or pushing back of what perhaps we've been deemed as inappropriate. It's okay to be upset. It's okay to be sad and frustrated. Let's be present with that and work towards addressing that in whatever context or experience you're having.
Thank you. Amber, your thoughts on the same question?
I do reality therapy as well, and choice theory. It's basically just what it says. Like, we all have a basic need to have our desires and our needs be met, and the choices we make are either going to help us do those things in a healthy, positive, productive way or not. Because I work with kids, I try to explain things very simply so that everybody can understand them. I use visuals. If you fall down and you get hurt, right? You hurt your knee. We can see your knee. We can assess it. We can treat it. It's going to hurt, but it's going to heal over time, right? You're going to look at that knee. You're going to be reminded of that day, but it healed. When it's your heart, when it's your mind, we can't see it. We don't know that there is a scar there. We don't know how deep it goes. We don't know how long it's been there. We can't help you if you don't talk to us. It's that simple. When we were kids, Black kids were not allowed to be angry. They just could not be angry. When I was 26 in 2006, when I went to graduate school, was the first time that anyone ever told me it was okay to be angry. Seriously, like I was shocked. Never in my life did I hear that. What's not okay? You can't act out. You can't curse and yell and throw things, of course, but you can be angry. And kids today have a lot to be angry about. Look around. And this is what I hear very often, that, you know, you don't deserve it. Like, look at this life I provide. Look at the things that I give. You don't deserve to be angry. Do we remember, be seen and not heard, speak when spoken to, do as I say, not as I do? There are a lot of things, again, trickling down. There are messages that we are sending to children directly and indirectly that we have to be aware of. The latchkey kid thing. We raised ourselves because we had to. My mother was an amazing single mother. So it's no diss. It's just, let's learn. Let's think about, again, those messages. So the things that I do is just try to listen to kids. I'm a chameleon. The kids say match energy. I'm a chameleon. I'm going to be who you need me to be. I'm going to be neutral. I'm going to partner with you and your parents. Again, I use stories. I use visuals. The family is a team. They're a unit, right? Everybody has a position to play. The caregivers, they're the coaches, not me, right? We're going to talk. Everybody's going to vent. We're going to get all the nasty stuff out. And then we're going to talk about how you're going to win. We're going to make a plan. I'm invested. You have to be invested. I can't work harder than you because it's your family. Kids have to be empowered in an appropriate way. We have to do it though. We as adults have to be involved in the process, no matter where you are. Teachers, coaches, whoever you are in the child's life, you have to take an interest and you have to listen. It's okay to be vulnerable. It's okay to let your guard down. These are things that we weren't taught. Again, the suffering silence. It's okay to say I had a bad day. Let's talk about it. Let's write something down. Let's do some yoga. Let's take a walk. Just being outside, the sun. Like, I mean, so many natural things, just things that we just take for granted sometimes. So just education, getting to know people and educating them and helping them make their quality of life be better in realistic ways that work in their lifestyle already. That's what I do.
Thank you. I like your answer. I like all of your answers. Nikia, your thoughts?
Amber, you were bringing up all sorts of things as you were talking, definitely reliving some things over here, right? So those are definitely words that were spoken, right? For me, I'm going to bounce back a little bit to elaborate on how I came into this field. I was young and I was a very, very active child. So my mom put me into dance class at 3. And little did I know, I was actually a dance major when I went to college, when I went off to college, and I was taking like movement therapy classes. And that's how I stumbled across psychology and fell in love with it. With that being said, when I was in high school, in middle school, high school, there were things that my dance teacher would do, and it was meditating. I had no idea. I remember laying on the floor and she would walk us through these things. And I remember, like you said, Amber, you know, children are, you know, there's no really expression. There's no talking about how you feel. So I would turn up my music and I would just dance. And that was dance therapy. That was me getting it out and just feeling good afterwards. It was like this natural high to be able to get out what I was feeling and the frustration or just anything. And even now when things are overwhelming and we have stressors and different things, I'm like, yep, time for me to go dancing. So just going out and being able to just like let loose like that just always felt so good for me. So for me, the type of therapy that when I was meeting with students, I'd focus on is mainly person-centered therapy, which was, I think in 1950s around there, was developed by Carl Rogers, and is basically focuses on active listening, empathy, unconditional positive regard, being able to provide that non-judgmental environment and allow the student, the child, the family to just self-explore and express themselves in a safe space. I love to incorporate mindfulness into the work that I do, even to this day with whomever I'm meeting with whether it's with my team, if I happen to have the pleasure of meeting with students and families, just incorporating different techniques, the breathing, body scans, meditation, those things are really important tools, I feel, for anyone really to learn and to know.
Thank you. Starting with Amber, what problems or life challenges can be helped by therapy? You don't have to list all of them. Leave some for your colleagues. And what are your specialties?
I think everything can be, discussed in therapy. Something like I get nervous when I take a test. I'm about to be an adult and I don't know what that's supposed to mean. I've been in a house for 3 years because of COVID and I don't want to go back outside. Anything can be addressed. Like I said, I'm used to dealing with more challenging situations. Most of my kids are very aggressive. They destroy property. They're involved in the court system. And when I tell you they are so respectful to me because I'm respectful to them, the behaviors that they exhibit elsewhere, I never have a problem with. What is on paper, I never see, because I really meet them where they're at and I try to get to know them. If you can't go through the door, go through the window, that's me. I might have to dig under the house. I'm getting in there. I'm going to figure out what I need to do to connect with the kid. I'm going to figure out what I need to do to connect with the parent too, because I know I need both. I need the buy-in on both sides, not one or the other, both, because at some point I'm going to leave and they need to be able to get along. So my specialty is really, they call me MacGyver. Like I got an award actually at our Christmas party because I'm going to figure out how I can get some cohesion. How can we function as a unit? Again, the same analogy with the knee. It's going to be better than it was. It may not be the best, but we're going to do something that moves us forward. I'm learning how to be patient. I learn from them just like they learn from me. We laugh, we joke, we listen to music. I get to know what they like. They get to know what I like. And it's just a regular relationship. I don't need to use jargon. I went to college. I don't need to prove that to you. I don't need to beat my chest to say I'm the authority figure. I don't need to do any of that. It's just very mellow. It's very laid back. And the beauty of what I do specifically is I'm meeting kids in their homes, in their communities. It's designed around their comfort to make them, hopefully be more engaged, because it's not an office setting. Like I'm at your house, you're in your pajamas, we're in your living room. What's up? How you doing today? It's a different interaction. So it's a little easier. It's not always easy, but it's a little easier.
Thank you. Nikia, same question?
So working with students with anxiety has been a number one. I would say anxiety, depression would be the type of student that we usually see that will come in through our doors. Definitely has heightened, right? Since COVID, the numbers have gone up. So anxiety, depression, and just, again, meeting the student where the student is really important. Energy doesn't lie. So you're going to, when you show up for students, they're showing up for you. I always say, and I get emotional even talking and thinking about it, we have such a gift to be able to be there for these children and families that it's just such a privilege to be, in an honor, truly, to be able to be there for them, to help them in times of need and just be able to help them figure out the things that they're going through. So showing up and being able to be there, being able to be that listener for them is something that I take pride in, and being, accountable, helping to hold them accountable, and just being trusting and being there for them.
Thank you. And Tina?
In terms of the things that can be addressed in therapy, if you're going through a transition, it's a great time to get into therapy. If you've experienced some level of trauma, therapy is A1. If you are exploring career opportunities and you want to identify, ways that you can enhance your strengths, or if there are challenges that you have experienced you want to resolve, definitely therapy is helpful. Any stressors, how to manage your stress, coping skills. I've had the pleasure of working in different realms. And so I've worked in the in-home setting, similar to Amber. And I've also worked with individuals in the group home setting. I've worked as a behaviorist. I've worked in the psychiatric emergency department. I still do that. And so therapy is very much tied to all different aspects of wherever you're meeting these individuals. Therapy is definitely helpful. I specialize in working with high achieving women of color professionals who are experiencing, let's say, high functioning anxiety or imposter syndrome. So those are that's my heart. And also really being clear about the way that social injustices impact my clients, right? It's not just what's happening on the inside, it's what's happening on the outside, and how is that playing a factor in your experience of your life and the way that you're going to navigate moving forward.
Good point to mention the outside influences as well. I'm going to combine several questions, and I'm going to start with Nakia. 3 questions in one. Describe a typical first session with a patient or client. How long does the session last? And what is the range in the amount of time in months or years that a patient or client sees you in therapy?
So
Starting with Nakia.
Okay. So a typical first session in a school setting for us would be contacting, would receive a referral for the student. The student will come in and the session would be very relaxed, getting to know the student, talking to the student about the referral, the reason why they're here in our office, right? Getting to know a little bit about the student. The student may know that the referral was already made for them. They may have self-referred. We have a large percentage of students that self-refer, or friends that may refer their friends because of a concern, or teachers may refer, staff member can refer a student. So our referrals come in many different ways. Typically, the student knows that they were either referred for counseling, and they're very comfortable usually in the setting. Conversation is held, just letting them know a little bit about what takes place in our office setting, how the sessions are held, how frequently the sessions are held based upon the need. And then there's some will call a biopsychosocial. We have an initial assessment that we are completing with the student. Typically that may be taken place over a course of 2 sessions, depending on the relationship and how comfortable the student is. There could be some icebreakers just to get to know the student so that the student is relaxed. The session can take, remember, my setting is a little bit different than Amber and also Tina. So we're in an academic setting. So students are typically coming to us either during a physical education class or an elective, and then they have to get back to their core academic classes. So our sessions may range between 25 to 45 minutes, really depending upon how the student is presenting and what is coming up. Sometimes we do have sessions that can last half a day, depending on what is coming up, if there's a crisis or other things that come out of that. Typically, once a student starts, our school-based services are supposed to be short-term. However, once a student starts services with school-based, they usually continue throughout until they graduate. It's a beautiful relationship that is built. And I can pretty much tell you, I would say about 80% of our cases usually go from freshman year all the way through. Even if it's, yes, we follow up with them, We reach out to them during the summer. We follow up with them in September to see if they want to restart services, and 80% always want to restart services or will come back. So it's not as common perhaps as outpatient or in-home services, but we usually see our students throughout their high school time that they're there in the high school.
Thank you. Let's see. Tina, can you tackle that one?
Sure. So I have a group private practice in Jersey, and as well as working in the psychiatric emergency department. But the therapy piece happens in the outpatient setting. And my first session focuses really on understanding what brought the individual in for services. And we're exploring the challenges they've experienced, the things that they've tried that have been helpful, the things that haven't been so great or not so helpful. I'm very intentional about expressing my expectations of them, you know, expecting that you're going to come to sessions, that you're going to be open to this experience. And I give them the opportunity to share what their expectations are of me. I talk a little bit about my approach in therapy. I talk about, you know, the discomfort of talking to somebody for the first time that don't know who you are. And just sort of like, again, it's that rapport building, getting to know one another, and understanding that just giving them a shout out even for just being present and showing up for themselves. So that's definitely something I think is important in terms of the time frame. First session's typically about 16 minutes, and then moving forward, it depends, typically between 45 minutes to 60 minutes each session. Frequency is also discussed during sessions, and then we sort of gauge based on meeting the goals that they've come in for services for. And so we might meet once a week and then move to bi-weekly and then so forth and so on. That is how therapy works.
Okay, thank you. And Amber.
So I give my kids a choice. Do you want to meet with just me or me and your parents? Like eventually the parent is going to join us. I have them define what therapy means to them and just explain to me what their experience has been thus far. We talk about what the referral states, like specifically. I always let them read it or I read it to them. I believe in full transparency. I always encourage kids to sit in on meetings, even if they don't want to talk. You need to hear what's being discussed about you, the beauty of what we do in our system of care. Kids have a voice. They are equal members of the team. No one is above the team. We all are the same, regardless of what your position is. We talk about HIPAA, you know, privacy, confidentiality. What you tell me is what you tell me. If I have to tell someone, it's because you know, threaten to harm yourself or others. If I have to tell anything, like if I have to report something to DCPMP, if I have to call the police, I always tell people I have to do this. Like it's never going to be a shock. I don't want to come into your house and pretend that I didn't know that this is going to happen. I prepare everybody, even a kid. I have to call. This is what I have to do. So they're always aware. They know. I don't ever want them to be like, Miss Amber didn't tell me. So we talk about everything that could happen. We identify goals. Like Tina said, we talk about what my expectations are, what I am committing to do for your family, and what commitments you're going to make to yourself. We discuss the schedule. Again, even though they're kids, I try to keep the same day, keep the same time, so they know on Thursday at 4, Miss Amber's going to be here. They expect it. So they know, I know. I don't need to call. I don't need to check in. They don't need to call. We're just routine. So they're good. We're teaching them how to be responsible. Everything is about how are you going to function in the real world. We're addressing your clinical needs. But, you know, I want you to be a little healthy person so you can go off and have the life that you deserve. So empowering them as well. The sessions can be anywhere between an hour or 2. Usually the intake is an hour. And what was the last one? It was another one, right?
Thank you.
Okay.
I think you've pretty much covered whether the session's just with the child or whether the parents are involved. I think all 3 of you have covered that. So I'm gonna skip that question. Starting with Tina, how do you work around the stigma within the Black community? How do you deal with it?
My perspective is, let's work through, let's be present and explore and address things head on, as opposed to trying to get around it. I
Right.
do think that it is very important. Again, like I mentioned, context, I say it over time, but I don't think that you can be an effective, for instance, I think that to be an effective therapist requires you to be somewhat of an advocate, somewhat of an activist, right? Like that you are aware of what's happening in the world. And for me, I need to talk about everything that's happened in the world in session. We're not just going to talk about your irrational thinking, right? We need to talk about the fact that you feel microaggressions at work. We need to talk about the fact that, you know, there are Black people who look like you being murdered on TV, and that you're seeing it on your social media feed. Like, we can't just talk about the stigma is continued to be perpetuated by so many other structural and systemic issues that it's just about talking through it and allowing them to be present, allowing them to be uncomfortable. I share also the fact that this is hurtful and painful. And so I think that that is helpful in the process of healing and growth, talking straight through it.
Thank you. Amber, same question.
I agree. I think validation is the key. I think we just have to have uncomfortable conversations. It's okay to be uncomfortable. I think it comes easier to us because we do look like our clients sometimes. I think we're the the conversation needs to happen is when the provider doesn't look like you and you are still uncomfortable and you want to be heard and understood, and you need to be, so that you can do the work, so that you can be vulnerable and you can let your guard down and you can tap into the things you need to so that you can heal and process. So we are trained to look at professionals as authority figures. And sometimes we don't feel comfortable to say, I didn't like that. You know, I didn't like that. Or I was offended by that. So in trying not to have the Black attitude or be the stereotype, you are silencing yourself. And the same thing that I'm saying, eventually you erupt and everything you didn't want to happen happens anyway. So it's just, let's talk about it. Let's just talk. Like, it's okay. Because you can tell, you know, when someone is feeling something, you may not know why. Just how check-ins, you know, just let's talk about it. You know, as a provider, if you notice it, just talk to the parent person, your client. If the client knows it, encourage them. Always open communication. Just, and that's what I say. Like, I'm not perfect. I don't know everything. If I do something, please let me know. I'm not offended because I need to learn too. I want you to feel like this is a safe, comfortable space. We just need to acknowledge it. And sometimes the reality is it just was a bad therapist. It's not therapy that they have the problem with. It just wasn't the right person for them. That's it.
Yeah. And Nakia, how about you?
Sure. Validation, like both said, community and access. I think those are three major things that I would state.
Thank you.
I just want to add to that in terms of the Black community, just being mindful that it's not a monolith, right? And so we talk about the Black community. Yes, that's an overarching experience, but also acknowledging that each person may have a different experience, and not to just assume.
Of course. I'm going to have Lisa show the slides. There is one slide that gives a suggestion for members of the audience who are who have a low income about dealing with the cost. If you can think of anything I haven't included in the slides that might be of assistance in enabling people, low-income people, to access the care they need, please suggest it.
Also, if you want to put your email in the chat, or Janet, you can put your email in the chat. You can reach out to Janet. I think I can't access the chat right now because I'm sharing my screen, but Janet, if you can put your email in the chat, then anyone who wants the slides can email you and we can send you the PowerPoint. So yeah, there's
Because
a lot of great information
okay,
here.
here we go.
Yeah.
Okay. Oops. See, when you're showing them that it goes away, I'll do it at the end.
Yeah. Yeah, so that will probably be the best solution here. So actually here is like, actually your email's not on there, Janet.
Okay, I will add it to the
Yeah.
chat after the slides.
We actually have a few minutes. If anyone has any questions, I think we can open it up. If you'd like to put it in the chat, I can check that for you, or if you want to just raise your hand or take yourself off mute, we can do that too. If anyone has anything they want to ask our three panelists about today.
Up with your questions, I guess I just wanted to share in terms of other resources available for folks who may have minimal funds. You can look at the actual providers if it's an outpatient setting, and asking if they have and they offer a sliding scale perhaps, or if they have pro bono, they offer pro bono. Some clinicians, myself included, make sure that myself and my clinicians have spots for folks who don't have the means, perhaps, based on their income. There are other resources like Open Path that's designed for folks who are uninsured or underinsured, and you can access clinicians who are invested in providing exceptional services to that community.
Tina, other than sliding scale of individual providers, could you put that in the chat so that I have access to the other sources that you just mentioned? And you can leave it to everybody, but that way I'll have it if anybody else asks. Also, this is the fifth year that I have done a program of this sort. Our community engagement librarian just put the previous ones in a mental health playlist that you can access on the library's YouTube channel. And this one will be on the library's YouTube channel, but we've got to give them a little bit of time to get it posted.
There was a question in the chat. Can you give examples of microaggressions? If the panelists
Any panelist?
I had a question. If actually our director Tanya Garcia has put a question in the chat. So for our panelists, can you give an example of how one can initiate the first conversation with a person that may need therapy? I find when the topic comes up, it triggers immediate defensiveness.
That's an excellent question.
Make sure that we're present to whoever mentioned that microaggressions question. And so that question first, I would say an example might look like, you speak so well. And, that might seem like a compliment. However, when directed at particular groups of folks, it is kind of like, why wouldn't I speak well? Right. So that's problematic, right? So microaggressions often sound like a compliment, but oftentimes we're speaking to an underlying something that's not really said, like you're the exception to the rule somehow. And lots of different types of microaggressions, but that's the first that came to mind. In terms of the other question, first conversation about therapy, I think it's really important to just be present with people. Just allowing them to share whatever they're experiencing, be sad, mad, frustrated, whatever it is, and come from a space of like an empowering one. I think people are more likely to engage in these types of services when they come from a place of like love as opposed to shame. Like there's something wrong with you. You need to be in therapy because you crazy. I mean, that's not very helpful, right? And I'm not invested in doing that, right? But if I can see that, we love you, we care about you, we notice that perhaps you're like kind of distant lately, is everything okay? Allow them to talk and be open about that. And perhaps sharing resources that are, I think you all had a list, sharing the resources that you have and staying in connection with those individuals is helpful.
I also want to say sometimes don't use those hot button words. You don't have to call it therapy, just talking to somebody. In preparing for this, I thought about the differences. We call them episodes. My aunt will call it a spell. Remember back in the day was the blues. Nobody called it depression. So sometimes you just might have to reword things and make it more palatable for them.
Good idea.
I definitely agree with that. The microaggressions are so subtle that you don't even realize, or most people don't realize, oh, you speak. I remember going to a nail salon and someone I was with made a comment about how I didn't know you spoke English, or you spoke, I didn't know, like it was just so subtle. Well, not that comment, that one wasn't subtle, but there's other subtle comments that are made within the profession, especially certain professions. And the higher you climb and the more you're around people that don't look like you, they are definitely there. As far as suggesting counseling and therapy to someone, using common lingo, right? Just being authentic and just open questions, just to kind of get them thinking about, or normalizing, therapy as well, I think is also important.
And before we move on, I just want to one more thing. Like, are things working for you? I mean, that's real clear cut, right?
Good way of putting it.
Are things working out? Not right or wrong. Is it effective? If it's not, let's try something else. Sometimes that just stops them right in their tracks, because it's not. Most of the time it's not. And then that will open them up to at least a conversation about, let me hear what this lady has to say. I may be okay with it. So just, again, like the more you know about the person, the easier it's going to be for you to figure out what they need you to say to get them in.
If I thank you for that. If I could just jump in really quick, I asked the question because I find that it's not only race or cultural, because I have 4 Latino sons, and it's gender, I think too, because when I bring up the conversation, and I always say, I think every one of us should go through therapy. So when I bring up the conversation of going through therapy, their girlfriends or their wife are all for it. Yes, I went, I go, I'm attending, I do this. And it seems like they champion them, but the men, they just clam up and they're just, that's not for us. We don't do that. We don't, that's not for us. And it's just
we're shifting, because you got to remember where it came from. We're shifting. We're having more people of color. We're getting more men, because yes, you need a man that they're going to be like, okay, we're going to talk about football, and then we're going to get to our feelings. Like, we want to approach them in a way that's going to draw them in too. So we see that too. You got the religious stuff. You have generational things. There are so many things that influence what we're seeing. It's so multi-layered, but it is a work in progress. There are not a lot of men, and when they are, they're not here. Like they're not here where we are sometimes.
Yeah, I always say that our culture, we deal with machismo, and it's not,
Right.
you know, even if we try, they have this. But I love what you said about are things working for you?
Yeah,
I
that's a
love
good
that. Love that.
Panelists, follow-up question on
Oh,
microaggressions.
just one moment. I just wanted to make a quick comment
Sure.
about what you mentioned, Tanya. I think it's really important to think about why we're in this space and why it looks like that, right? We notice that women tend to be more expressive of their emotions and mostly sadness, right? But it's socialized, right? Like we tell little boys, right, that come on, be a man, right? Like and then relationships, the other intimate things, right? Then it's like, why won't you be expressive? Why won't you tell me how you feel? But like they grew up all the whole time and you told them not to. Now we're upset that they're not going to therapy, which is shifting on the side note. But
Right.
I think that it's important to realize how things have been and be an active participant in shifting the narrative for people in your circle, right? We can be the change. Like your cousins, even if you don't have children, and your students, whomever, like let them know it's okay. Your sister saying something to their kid, be like, yo, sis, on a side note, it's okay that he likes this. It's okay, right? So that's how it all shifts. It's going to be progressive, but I think that's an important thing to consider when we're thinking about like men going to therapy.
Quick follow-up on microaggressions, and then David had a question. Do you ever find that the microaggression is so subtle that the insult doesn't even hit you until you get home?
Sometimes.
Okay, so I'm not imagining that. Okay.
Mm-hmm. Yes.
Okay. David, what was your question?
Hello, everybody. This is the first time that I'm speaking. I'm the library social worker at the Long Branch Public Library. I know a lot of you already, and it's nice to match the face with the name. So real quick, I just wanted to say, as far as like therapy question, I just wanted to comment on that because, you know, one thing that I've learned working in this library setting, which is truly a micro, meso, and macro setting here in the library. But what I've learned is that as a result of the conversation that you have with the client and or your intake process with the client, the conversation will lead you both into the type of conversation that will refer to maybe therapy. One of the hardest things about therapy is the stigma behind it, in particular what we're talking about, the topic matter of this discussion. I'm Puerto Rican. I was born and raised in the Bronx. And when it comes to microaggressions, you know, I've been dealing with that my whole entire life. I'm actually a redhead Puerto Rican, which is very rare. And, you know, I've had people say like to me, like, you know, I never knew that Puerto Ricans had red hair. You know, I never knew that somebody who was born in the South Bronx could actually get a master's degree. And maybe they're not saying it like that. And just to answer you, or to comment on what you just asked, Janet, sometimes it's so super subtle that you don't realize until you get home. But sometimes it is absolutely blunt. And but it's all microaggression. And the ones who are impacted by microaggressions are going to be us right here, us vulnerable minorities, people of Black, brown, people of color, Asian, LGBT, you know, women in general. We're all going to, if we're not a part of the dominant paradigm, then we're going to experience some sort of microaggression at some point. And I love that we're having this conversation. But I think, you know, to speak directly to my director, Tanya, you know, when it comes to the therapy question, you know, I've always tried to, you know, not directly go there and sort of strategically, you know, structure my conversation to where, you know, we might now be staring at that thing all of a sudden where the person doesn't even realize how we got there. And I just kind of let that person bring it out, you know, if I can even do that. You know, which is a skill that you know we all need to develop. But anyway, that's what I wanted to say, you guys. this was a great discussion.
Thanks. Lisa, you had a question also?
Yes, hi. I think mine is mostly for Nakia because you work with the students, Nakia. I was just curious if child needs to come and see you and is referred, do the parents have to consent to that? Or can the child still come and see you without that parental consent? And then do you sometimes run into the issue of the parent does not want their child to have to come speak to someone or go to counseling?
Great question, Lisa. So we do have consents within the school-based service program. We do have consents for students that are age 16, well, 15 and younger. Once a student turns to age 16, a consent is not warranted, but we do like to obtain the consent, let the family know. And of course, when we make phone calls home, it's all in how you present it. We just graze around the conversation unless it's something specific that the family member really needs to be aware of, or unless the family member requested the service for themselves, for their child. So we do let them know that counseling is taking place, with permission. Consent is sent home at some point. The consents usually go out to all 9th grade students. And once they're consented from 9th grade, then we have it already on file all the way through their high school time. We have had students, families that do not agree for counseling. So one way around that and allowing a student to have the opportunity to talk to someone in school is through guidance. A lot of our guidance counselors are LPCs, so they're able to provide the counseling services through them or through our SAC that does not require consent. If a student is 16 and older, of course, they can just not be consented, or if they're 18, they can sign for themselves. It's not typical that we have a student family that does not want services. It's a very, very small percentage. However, there's been times where if a DCP&P call had to be made, parent guardian requested to no longer have services, and then we just have to honor their wishes. Even though the student may still want to, we just have to honor what the parent is requesting, and we would just refer the student back to their school counselor.
Thank you. That's fortunate it's not that large a percentage. And it's good to know there are some ways you can work around that if you need to.
Absolutely. And just keeping confidentiality. And one of the reasons why our students don't always want the families to know everything that's going on. So maintaining that confidentiality, having the families be a part of it is important. When we feel that component definitely comes up and it's well needed, we do invite the families in with the child's permission, and or we refer out to services within the community.
Thank you.
You're welcome.
Are there any other questions? I don't think I see anything else in the chat. And I see I've gotten a lot of your email addresses, so we can send out the slides. So Janet, unless there's anything else, we are at
No. I just want to thank Nakia and Tina and Amber so much for your participation, and thank you to everybody who attended.
Thank
Thank
you,
you so
everyone.
much.
Thank you.
Thank you for the great opportunity.
Have a good weekend, everyone.
Yeah, it was great to see everybody. Have a
second
good
that.
weekend.
Thank you.